right, well, let's get started. Alicia and I will be doing our own individual answer sheets. I got one, she's got two. Carrying the load, she is. So we're going to be covering endovascular cases. We started that last month. We got through a couple of the endovascular. So we're going to finish that up. And the E&M one that we didn't get to the last webinar, we got that in here. So I think you'll enjoy this. Pretty meaty stuff. This is a slide where we like to encourage everyone to become a club member. And as a club member, you get access to the recordings, which we call replays. You get the slides, you get all the answer sheets that the interns and us tweaking what the interns did. You get all that valuable stuff. And of course, in the club. We do these live broadcasts so everybody can listen and learn for free. But if you want the CEUs and all of the goodies, then we do need your support by you becoming a club member. And we have two ways that you can do it, or actually three. You can become a monthly club member, which is only $24.99. This is where you get the always open access. We're actually going to be changing this. So if you are already a monthly club member, we encourage you to not let that lapse because we're making changes. The Batcave access and access to previously purchased courses that have expired are no longer going to be a bonus or a benefit for monthly club members. That is going to be reserved for the annual club members. And I'll be honest, be completely transparent. We have some people, unfortunately, that come on and go off, and administratively, we have to add them back to all the previously purchased courses, and it ends up costing more money to manage that than we're actually making. And we need the money to support the development stuff. So we're going to make those bonuses or benefits for annual club members. So keep that in mind. If you're a monthly club member, hang on to that. You'll be grandfathered in. But if you let it lapse, the only way to get it back is to become an annual club member. And annual club membership is $249. So basically you're getting 2 months for free, or you save $50 a year, whichever way you look at it. The CCO Club Plus, that's when you want to do a course and the club, and you pay $329 to get in, but then it's only $99 a month, and you can take all the courses if you want. And you get to take, we are making a new change. It used to be one course at a time. Now we're going to let you do 2 courses at a time. So if you want to do medical terminology and physician-based coding, you can do that. And then when you finish one and you want to take another, you just let the help desk know through the Academy app, and they'll get you set up for that. And any course that you complete while you're a Club Plus member, even if you downgrade to the annual, you'll get continued access for as long as you stay an annual club member. But we have one more slide. We have a sale. We mentioned this last webinar where it's instead of $249 for the annual, it's $199. And we did this in honor of the new launch of our CCO Academy app. So if you want to get in on that, $199 for a whole year. So now you're in essence saving $100 a year over doing the monthly. This is the link. When Alicia starts to do her presentation, I'll put this link in the chat so you can go direct to it, but it's right in the app.
And you were just saying that you've had several people take advantage of that sale. So
yes,
and they're enjoying it.
Yeah, I got a good interest after the last webinar. So, okay, so Alicia's up first. And if you want to pull up your answer sheet and share that, do you have it pulled up?
I have it pulled up. Oh, there's the button. I almost hit the going out the door button.
No, don't.
I hovered. I was like, that. Wait, stop. Okay, hold on. Let me just pick which screen to show you here. Let's see. I've got things on 2 separate schemes. Was it 1459 or 1458?
59, the endovascular cranial.
Okay, I'll just share that screen. Okay, got it. Sorry about that, guys.
You're good.
That's what happens when you have 3 monitors going at one time, right? Well, as you guys remember, as we get back to doing these fabulous webinars like we did in the past and giving you an answer sheet where the content flows versus a slide deck, one of the things that we wanted to highlight is that we cover the questions that you send us. And if you're in the club, if you're a member, then of course we'll pick your questions first. You get priority. However, we need to hear from you about the questions that you want unpacked and more information on. That being said, we want to give a shout out to Beverly. Beverly is one of the CCO club members that wanted more information about endovascular cranial coding. Our intern, let's see, Priyanka, she is the one that prepared the slide deck, and then myself and Laureen are the ones that get that information. And again, Beverly had asked, can you just give us anything on endovascular cranial coding? And we did. We found some great stuff. First, it's very important to understand what endovascular cranial procedures are and how they work. If you don't have that foundation, then it's a stumbling block moving forward. I have found now by doing a lot of both clinician auditing and coder audits that if the coders, I can tell when they don't have that foundation under their belt. And unfortunately, that makes them slower. It makes them not hit their benchmarks. And why make that happen? If you're going to be coding in a specific area, if there's something you don't understand, get out there and do research, or let us know and we'll help you out. So looking at the endovascular, it typically is minimally invasive procedures most of the time. And what they're doing is ultimately is they're working within the blood vessels themselves. And when you say cranial, then of course it's going to be in the brain. And a lot of times it'll be neurological and vascular conditions. So keep those in two separate boxes. We have a neurological condition that is the brain tissue itself, the brain, or a vascular issue, which is going to be the blood supply to the brain. Two separate categories. Now, how do they actually do these procedures? A lot of times you'll see references to the catheters that are used, which would be the tube or the lumen that they're going to put wires. These are very fine, tiny little micro wires. And a lot of times there'll be imaging guidance. Now, with this imaging guidance is usually fluoroscopy. And it's real easy to go out and do research. You can see, put in your Google search, fluoroscopy images, and it'll show you some. I think we've got some here for you to see what that looks like. But know that you're working with minute little vessels and in an area where you can't make mistakes. That's why they have imaging. And a lot of times in the codes, you'll see with or without fluoroscopy and or imaging guidance, and then sometimes you'll see it two separate codes. So pay very close attention to your code descriptions to see if the fluoroscopy or the imaging guidance is included in that code or not included. That being said, the procedures a lot of times will offer alternative to traditional opening up cracking the skull and getting into minute little vessels. It really is nice too, because even though it's invasive, it's a smaller incision area, and it means faster recovery, fewer complications. Interventional radiology is huge. They're finding that it's more than just working on the heart. We're using it for all areas of the body that have a vascular system, which is everywhere, because they can get in and take care of a bleed or a problem even before the patient goes into surgery. They can do it that fast, which will prevent a lot of problems during the procedure and save time for other procedures, like if there's a massive accident or something and it doesn't have to be just head trauma, throughout the whole body. Now, the conditions that are being treated, a lot of times you're going to see things not just in the brain, but remember, neurological is the brain, and the spinal cord, and then the nervous system going out. So we have central nervous system is the brain, and the spinal cord, peripheral is everything else. And we have, just like the vascular system, it's all over our bodies. Neurology isn't just about the brain. However, one of the common things is a brain aneurysm. And it's brilliant that they're able to treat a brain aneurysm this way because, again, it's less invasive. Now, it could be called a cerebral or an intracranial aneurysm. Cerebral is your brain, and it's a part of your brain. Intracranial just means anything inside the cranium, so past the skeletal part. And ultimately, the easiest way to remember an aneurysm is that it's just a little weak spot in the vessel, and it makes a balloon, a little bulge as that tissue wears out. Now, this causes a multitude of problems. One, there's the fear that you're going to rupture. And when you're talking about vessels, whether they're veins or arteries, you could bleed out pretty quickly. And remember, the brain doesn't repair itself. So if you get a buildup of pressure, it is going to damage tissue in the brain as well as not get the blood supply. And so there's a lot of reasons why that is problematic. And then the potential of rupture is probably the number one thing that we're trying to prevent. But there's other things that aneurysms can cause. Sometimes they're very, very tiny, which again, we're looking at little tiny vessels, but they can cause, the aneurysm itself can cause bulging and pressure. An aneurysm isn't necessarily ever going to be felt or noticed. You don't get signs and symptoms usually with a small aneurysm, but you could. The other thing is that when the blood flow isn't smooth, then the body starts trying to compensate. And if the body or the brain detects that the blood is not running through the system correctly, it might run more platelets, right? If you got a bulge, it may think that there's a hemorrhage there. That's why people with AFib, end up getting put on anticoagulants, because of the arrhythmia makes the brain think you're hemorrhaging, and then you get a clot, and as we know, that can happen. That can be quite serious. So the same thing can happen with aneurysm. So if a known aneurysm, no matter where it's at in the body, they're probably going to be put on anticoagulants. And again, it doesn't matter what type of vessel it is if there's a bulge. Now, arteries and veins are different. Arteries have that elasticity, more likely to have a bulge. Veins have valves that keep the blood flowing in one direction. You can still have a bulge in a vein. That's where you get varicose veins, right? They're all bulgy. However, we tend to think aneurysm artery more often because, again, it loses that elasticity and starts to balloon out. Doesn't have to be that way, though. Blood vessels that have malformations or fistulas, these are called AVMs, or arterial venous malformations. This is when you get like this abnormal tangle of blood vessels, and it causes problems where they twist up and knot up. You can imagine how intricate these vessels are throughout the body. This is usually a congenital thing, but not always. If they start becoming malformed, or think of a mass of in your legs, what am I thinking of? I just said it, the veins and everything, varicose veins. But think of a whole bunch of veins being varicose veins in a cluster. That's kind of what's happening. It can be a malformation. You can have a fistula where it closes down on there, and that, again, that arterial malformation is going to be most often abbreviated AVM. So that's something to write down in your notebook if you weren't familiar with that term or abbreviation. Let's see. If you have one in the dura, which is that hard membrane, that it's not hard, but think about the shell, the membrane in an egg. So between the white of the egg and then that membrane and then the shell, that membrane is what we think of as like the dura. It's really quite durable. That can be a dural arterial fistula. If we do have a rupture of an aneurysm or a clot, then that can cause a stroke. And two types, we have ischemic and hemorrhagic. They need to identify which type it is very quickly, because the treatment or the plan of care for each of those is going to be different. Hemorrhagic, you're not going to give a clot busting blood thinner like TPA because you'll bleed out. But ischemic, where there's a clot, that works really well. And sometimes it can even take away all the signs and symptoms for a short while that's working. And again, just remember that's a clot that can happen. And here's an example, this little area that they've got highlighted where you have a bifurcation and then you've got a little fat tissue or a piece of atherosclerotic tissue that breaks off and just gets caught in that bifurcation. No blood's getting through, and you're going to see signs and symptoms almost immediately when that happens. You can also have tumors, and the tumors can build up extra blood flow to those tumors. Now, we don't always realize that when we're thinking of cancer. We think, okay, there's a mass. Let's say there's a pea-sized mass in the brain, which could be really problematic, even though it doesn't seem like that would be very big. Another problem is that tumor, to feed the tumor, it develops more blood flow. The vessels grow and start wrapping around like the roots in a tree. And that causes problems. That supports the tumor growth. So sometimes they go in and they cut that blood supply off. And that in turn would make the tumor not be able to be fed. The common endovascular cranial procedures is divided up in endovascular coiling. Now, they usually use this to do aneurysms. So what they do is they take these platinum coils. So platinum doesn't deteriorate like a copper or other types of wire. That's why people want platinum jewelry. It doesn't wear out. And then they, through the vessels, they run that up in there, and that coil supports the vessel so that it can't balloon or break. It gives it support, and it literally looks like a coil or a spring. Mechanical thrombectomy. Now, this is really cool because when you have an ischemic stroke, like what we were seeing where that clot was at that bifurcation, they will go in and they'll go through a large vessel, and it'll just get smaller and smaller as it bifurcates. They'll put a stent in there. They can retrieve or even bust up that clot and pull it back or aspirate it back into the catheter to remove the blood clot. Pretty easy, right? And so that's pretty amazing. They've been doing that for quite a while. And then there's an embolization procedure. And this is where they're going to go in and stop a blood supply. They treat things like those AVMs that we talked about, or the dural arterial venous fistulas. That, by the way, is abbreviated with a DAVS, if it's plural. The synthetic materials like those coils, sometimes they have particles or even liquid agents that can go in and block that blood flow, kind of like a super glue that hardens real fast. They use that to treat uterine fibroids now. They've been doing that for a long time. And so instead of having a hysterectomy, you can go in and through that vascular system, and they'll put these little pebbles in there that'll kind of blow up like bulba tea, and that'll stop the blood supply. And then the fibroid either it starts to shrink because it's not getting blood, or it doesn't grow anymore. So it's been done for a long time. They can do it in the brain as well. And it's pretty fascinating. They can also do flow diversions. And the way that's done is they put this special agent into the blood flow, and it's away from the aneurysm, and it allows the body to heal the aneurysm over time. Kind of fascinating. I think this is an area that's growing a little bit more, relatively newer. But one area that we've been doing for ages, it seems like, is angioplasties and stenting. And when we started with breaking off interventional radiology as its own department. This is the bulk of what they were doing, angioplasties and stenting. And a lot of times it was done with the heart, and then they would do the brain. Now they do these everywhere in the body. So it's quite a fascinating area to get into. It is an area that needs coders, interventional radiology, as that has grown and become quite an amazing specialty. And for these, if you have atherosclerotic disease or intracranial or ischemic atherosclerotic disease, that's when those arteries inside the brain start getting narrowed. So we're not talking about the outside. Remember, you have vascular system going inside, and they clog up. Now, what are the advantages of doing this type of procedure? The number one is that it's minimally invasive. So it really requires a small incision versus having to do like a craniotomy type thing where they will make a large incision and either do a burr hole or some way to get into the skull itself to the brain. And they make this little incision. It can be done at the wrist. It's often done at the groin area. There's shorter recovery time, of course, and there's fewer complications because it's, even though it is a major surgery, it is less invasive and the healing time is much better. There's other reasons which it would be something that you might want to practice is the pros and cons of having these type of procedures. Write them down in your notebook, and you'll see that they'll talk about that in the op report when they consulted or counseled the patient on these procedures. So now let's get into those codes. Now, it seems intimidating. It had always been intimidating to me in the past, but once you get this under your belt, you're going to realize that this isn't difficult at all. Pay attention to the descriptors in the area. So this is where the bubble and highlight really truly shines. Okay, these areas are going to be bubbled, and you're going to highlight and underline the key terms that will keep you in the right area. So the endovascular cranial procedures are going to be 61623 through 61651. And again, these are endovascular therapy procedures. They're on the skull, but not just the skull. We're doing the meninges and the brain. The meninges is part of that system. The specific codes in the range, and we're going to look for those key terms. Again, endovascular. Now, note, this is 61623 is a temporary, but it's a balloon. So you would want to highlight that. So we'll just make that yellow. And we also know that it is arterial occlusion, okay? So the arterial is the vessel that is being done, but an occlusion means it's completely blocked. Now that's pertinent to understand that. But then the key is the specificity. This is the head or neck. So the endovascular, but if it's not in the head and neck, it doesn't matter. You're in the wrong place. Then our next code, the next two codes, 61624 and 61626 are transcatheter permanent, okay? Different than 3. This is a permanent occlusion or embolization for central nervous system. So we're going to underline that when you do your bubble and highlight. Or the next one is non-central nervous system, head or neck. Okay, very key. If we aren't going to, now an occlusion or embolization, occlusion means nothing's getting through, and an embolization is another term for that. So that's what I had done on my fibroid, was an embolization. Then we get into 61630. This is also a balloon, but it's an angioplasty. So they're looking at atherosclerotic stenosis, right? So this is a angioplasty. So we're going to make that yellow. And then the other code, 61635, is the stent placement, right? But notice we're not done. With or without an angioplasty, okay? That separates those. 61645, intracranial percutaneous arterial transluminal mechanical. That all sounds intimidating, but here, it's a thrombectomy. They're going to go out and they're going to go get the thrombus or the clot. That includes diagnostic. Very important to remember, diagnostic is a key term. That means they don't necessarily know what the problem is. It's still an angiography, and they do catheter placement. Now, considerations. When you go to code these, you have to think to yourself, is there bundling? So right here, we see that with or without angioplasty. So if they go in and they do this intracranial angioplasty, then you're going to use the 61630. But if they put a stent in, then you're going to also use 61635. Can they put a stent in without the angioplasty? Yes, that would be the 61635 by itself. So that's where you get into the bundling. Be very careful. Vascular territories are important. We've talked about those in the past, and you're going to see those on YouTube. And then also look at the documentation where I've highlighted and underlined these words. When we talk about endovascular cranial procedures, this is our key. These are the key terms you want to look at when you do your bubble and highlighting. And I think that wraps us up, Lori. Can you grab it, or do I need to stop sharing?
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.